In this segment, I'm going to talk to you about cancer pharmacogenomics. So why is pharmacogenomics relevant for cancer treatment? Well, many cancer therapies are toxic, actually, and have severe side effects. They're great for killing tumors or getting rid of malignant cells, but are toxic to the rest of the body a lot of times as well. They often have narrow therapeutic indexes, which means that the amount of drug necessary to be effective is very close to the amount of drug where you start getting really toxic side effects. So there's a narrow window there. Prompt diagnosis and treatment is vital in cancer settings. Oftentimes these are rapidly progressing diseases, and you need immediate efficacy to fight this. There's a large need in the cancer therapy to increase efficacy as much as possible, and yet at the same time minimize adverse events, as you can imagine. So when talking about cancer pharmacogenomics, we have to pay attention to the tissue that's involved. So in normal tissue with germline DNA variants, the polymorphisms, the variation in these genes is the same as throughout the body, okay? So it's just your typical, if you genotype a patient, that's the genotypes that you're dealing with there. But then you also have the tumor DNA, okay? So in the malignant tissues, in these tumors, the cells are known to be mutated. That's why they're tumor cells. And so they have alterations of that regular germline DNA that's in all the rest of the cells. And so those variations are very particular to the tumor. Even within a tumor, you can have cells that have widely different polymorphisms in it. So it's completely different if you genotype tumor cells than if you genotype the patient themselves. And that's important to know the difference there. Many times, the efficacy of a drug is based on the tumor tissue. So how well the drug is fighting the tumor tissue. So that's based on the pharmacodynamic genes in that case. So the drug is targeting the pharmacodynamic genes. The mechanism of action is against the genes in the tumor cells. So the variants in the genes, in those pharmacodynamic genes, are oftentimes used to select the treatment for that cancer or to predict the efficacy of it. So oftentimes tumor cells will be genotyped for the PD genes so that you can determine which medication to use or how well the medication might work. The toxicity of the cancer drug is a lot of times based on normal tissue genotypes, the variants that are found in the PK genes in the normal tissue cells, in your liver cells, because you're looking at how well you can metabolize the medication and get rid of it from your body. So as the medication builds up, it becomes more toxic to you. And we've discussed this in other sections. So variants in these PK genes in the germline cells are often used to make treatment decisions about what might be too toxic or have adverse side effects that are too severe for that particular patient. So most of the time, these cancer drugs work well statistically, right, for most of the population, but there are a few that are going to not be able to metabolize the medicine well enough, have two adverse side effects, which is very severe in the case of cancer, because you're willing to tolerate quite a bit of side effects in order to eradicate the disease. But there are still situations where the side effects can be too great. So here's a list of some cancer PGX examples. The genes in red are PK genes, and so we're talking about, in this case, genes that are genotyped in normal tissue, and they influence the ability of the patient to metabolize the drug. And then in blue, we have the pharmacodynamic genes at the bottom of the screen, and the drugs that go along with those particular genes. And we're talking about, in these cases, genotyping the tumor to find out about the genotypes in these particular genes. Diagnostic tests are used to select targeted cancer therapy most appropriate for the patient's tumor type. So the genes in blue here are typically used in diagnostic tests where the clinician is trying to determine if this medication is appropriate for that particular cancer form. So I'm going to go through a few of these examples of both normal tissue PK genotyping and tumor tissue PD genotyping. So we're looking at the PK genes. We're looking at TPMT, DPYD, CYP2D6, and UGT1A1. We already talked about thiopurines and TPMT in a different section in the pharmacogenetic examples lecture. So I'm not going to cover that again here. You can refer to that one for the discussion about how TPMT works to metabolize thiopurines. So I'm going to talk about DPYD and fluoropyrimidines first. So 5-fluorouracil, or 5-FU for short, is 80% metabolized by DPD, which is the enzyme encoded by the gene DPYD. The enzyme converts the 5-FU, which is an active form of the drug, into an inactive metabolite called DHFU. So DPYD is helping to clear the drug. In the population, there is a small yet significant percentage that are either partially or completely deficient for this enzyme. They would be at great risk when taking this particular drug because they can't clear it properly. Okay? The toxicity from this drug includes things like severe things such as myelosuppression, neurotoxicity, all the way to maybe more mild, but still sometimes severe side effects such as diarrhea and mucositis. So in these cases, if you can partially metabolize the drug, you may not have super severe side effects, but if you can't metabolize the drug at all, you have very, very severe side effects that can become fatal. The drugs that people actually take are Tegafor and, I don't know how to pronounce this one, I think it's capecitabine. Those are oral prodrugs, so those have to be converted into the 5-FU drug in order to be effective. The DPYD gene does not encode the enzyme responsible for that particular step, but again, just encodes the enzyme which helps clear the 5-FU from the system. Let's see. I'm going to show you a pathway briefly. This is the 5-FU drug right here. So this is a prodrug that is taken, how it is metabolized into the 5-FU, which is the active metabolite, and then its efficacy is through this route, and then it is cleared out through other processes. The DPYD step right here is the, whoops, I can't highlight it. Okay, this DPYD step right here is very important for clearing the drug out. Otherwise, you get a buildup of it, and it becomes toxic in the system. On the FDA-approved label for 5-FU prodrugs, they have a warning that tells people that you're at high risk if you have DPD deficiency. So on the label, it states people with lower absent DPD activity, which is the enzyme encoded by DPYD, there's been evidence of acute early onset or unusually severe toxicity. And they even go further to say that there's no dose that has been proven safe in these people. However, they do stop short of saying that you should test for it before you give the particular drug. So that's kind of interesting that even though they acknowledge the fact that there's no dose safe for people that are missing that enzyme activity altogether, they still don't make an actual recommendation for it, but they do give some information about the fact that you must monitor people very closely and that people with decreased activity are at increased risk. So the CPIC group wrote dosing guidelines regarding this gene and drug, and they took it a step further. So they do recommend, if you have the genotypes already in hand, that you should be using those when dosing this particular drug. So here's just a chart that explains that people who have one copy of the wild type gene and one a deficient copy of the enzyme, they would need obviously decreased dose of the drug, 30 to 70% of the normal population. They actually recommend starting with about 50% reduction and then titrating up from there, just to be safe and to prevent adverse drug reaction. In people with complete deficiency, the recommendation in this case is to select an alternate drug. As it said on the FDA label, there really is no dose that is safe for those particular people. Okay, I'm going to talk about CYP2D6 and tamoxifen. Only about 7% of tamoxifen metabolism is dependent on CYP2D6. Actually, the majority of it is metabolized by 3A4 and 3A5. But I mentioned in a different lecture on cytochrome P450s that there's not a lot of variation in CYP3A4 that really influences drug metabolism. However, there's huge variation in CYP2D6. And even though only 7% of the drug is metabolized via CYP2D6, if you're a poor metabolizer for that particular gene, you still may suffer from not as much benefit of the drug as somebody who is wild type. This is a somewhat controversial association for a few reasons. For studies, some studies have shown a clear association, some have not. And there have been many studies on the subject, and they go both ways. Part of the reason for the difficulty in replicating this particular association is because CYP2D6 is a difficult gene to genotype. There are many, many variants, and you also have to be careful to look for gene duplication, which a lot of times is not always done in research settings. In different studies, people have looked at the tumor genotypes versus normal tissue genotypes. As we mentioned earlier, there's a big difference there. Tumor tissue is known to mutate, and so will not necessarily have the same CYP2D6 genotypes as in the normal tissue. So you may be assigning a metabolizer status to a patient that's different than you would have if you're looking at tumor tissue than you would have if you're looking at normal tissue. Also, the endpoints used to measure success in a lot of these studies varies wildly. So sometimes you're looking at death, avoiding death. Sometimes you're looking at avoiding recurrence rates for breast cancer. Sometimes you're looking at just adverse events during treatment. So the multiple endpoints used to measure treatment success also contribute to variation in these studies and have led to a somewhat controversial association between 2D6 and tamoxifen. I want to show you, this is the pathway. Obviously, there's tamoxifen in the middle. As I said earlier, a lot of the tamoxifen is metabolized by other genes, including CYP3A4 and CYP3A5. About 7% goes this route through CYP2D6. The DPWG has still written guidelines for how you could use CYP2D6 genotypes when dosing tamoxifen. They recommend for poor metabolizers and intermediate metabolizers, so people who don't have the normal metabolizer status, a little bit less than them, that they get an additional drug, an inhibitor, along with tamoxifen, because they're at risk for having decreased benefit from the tamoxifen alone, because they can't metabolize as much as tamoxifen. So they're at increased risk for a relapse, and so they recommend prescribing this other drug as well. There's no, they have no recommendations for what to do for an ultra-rapid metabolizer at this time. Okay, the last one of these that I'm going to talk about is UGT1A1 and irinotecan. In this case, UGT1A1 metabolizes irinotecan into SN38. SN38 is the active metabolite of the drug. I'm sorry, it doesn't convert it. The irinotecan needs to be converted to SN38, which is the active metabolite of the drug. But the UGT1A1 is responsible for converting SN38 into SN38G. So it's responsible for the glucuronidation of SN38 to an inactive form. So this again is an example of clearing the active form of the drug. UGT1A1 contains a promoter region repeat. So it's a bunch of TAs over and over again. So 6 copies of the TAs in the promoter region is what's considered wild type. Normal activity, so star 1. If you have 1 more TA group, so you have 7 repeats of that, you're designated a star 28. Star 28s have a decrease in transcriptional activity by 70%. So remember, this is a repeat in the promoter region, so it influences transcription of the gene, and that 1 extra repeat means that there's a lot less of the gene being transcribed and a lot less of the enzyme being made. In different populations, this variant is found in different frequencies. You can see the highest frequency is in the African descent population, and probably the lowest frequency in Asians. But you can see that it's still pretty significant. We're looking at anywhere from 9% to over 50% of any given population having a star 28 variant, which again means a lot less of that particular enzyme and less of an ability to clear the active form of irinotecan. This is the pathway here. SN38 is the active form and needs to be cleared by UGT1A1. It's pretty much the sole mechanism for getting rid of the active form of that particular drug. The DPWG has written guidelines for this. In this case, if you have just 1 copy of this defective gene or gene which is responsible for decreased transcription, they don't recommend any kind of change in therapy. However, if you're homozygous for it, then they really think that you should reduce the dose, because with at least 1 copy of the wild type gene, you're able to metabolize the drug to a sufficient degree so that it doesn't have some toxic side effects. However, without that metabolism, with a much decreased amount of enzyme in your body from being homozygous for star 28, they recommend a decreased dose. This is mentioned on the FDA-approved label for irinotecan as well. They do mention that people who are homozygous are at increased risk for some side effects like neutropenia, diarrhea, and so forth. They say that if a person is known to be homozygous for the star 28 allele, to reduce the starting dose. Again, though, they make no recommendation for preemptive genotyping. There's a group in France who have come up with some much more detailed dosing recommendations for irinotecan and UGT1A1 genotype, but it basically boils down to the same thing. They have a nice diagram that steps you through it, what happens if you're homozygous wild type all the way to homozygous for star 28, but in the end, the same thing is recommended, that you decrease the starting dose for those who are homozygous for star 28. I'm going to go over just for a few minutes the kind of other section of Cancer PGX, which is when we're looking at the drug targets for these particular cancer therapies and the genes involved in the tumor tissue. In all cases, these are considered, the genes are considered biomarkers for these drugs, and the FDA requires testing before prescribing the drug. Erlotinib has an association with EGFR. EGFR is an epidermal growth factor receptor. It's found on normal and cancer cells. In some tumor cells, signaling through this receptor plays a role in the tumor cell survival and proliferation. Sometimes irrespective of EGFR status, but it's still part of that cascade. So there are targeted therapies whose mechanism of action is to inhibit that EGFR kinase activity and the downstream signaling from it. Erlotinib is a particular drug that has increased affinity for particular variants of EGFR. So variations of EGFR where exon 19 is completely deleted, or there's a particular mutation in exon 21, it has increased in affinity for those particular variants. So this is a pathway of EGFR and how, you can see this on PharmGKB and look at it in more detail and read about it, just part of that cascade and how it leads to cell proliferation and survival. So the FDA, as I've said, requires testing for EGFR status before prescribing erlotinib. Same with the EMA, the European Medicines Agency, and the FDA equivalent in Canada. They all agree that this is something that is required testing before you can prescribe this drug. This drug is typically used to treat metastatic non-small cell lung cancer tumors. There's a different drug that is also related to EGFR called cetuximab. However, in this particular drug, when it was developed on the label, they acknowledged the fact that even if you block the EGFR, there can be downstream activating mutations in another gene called KRAS. If you have the activating mutation in KRAS, then actually inhibiting EGFR is not effective. And so in this particular drug label, it was approved for not only do you have to show test for EGFR, but you also have to test for KRAS to make sure that it's KRAS negative. That's the only time, and this diagnostic test is required because if it's not KRAS negative, the therapy is not recommended because it can bypass blocking the EGFR cascade. The same recommendation is not made on erlotinib, which I just talked about. So they don't make any mention on that drug label of KRAS, but there have subsequently been studies done where it's probably true for that drug as well, that KRAS positive genotype, erlotinib will not be as effective in those situations. But the drug label has not been updated as yet. So for erlotinib, the requirement is just testing for EGFR, whereas for cetuximab, we're looking at KRAS and EGFR, so a double diagnostic test. Imatinib is a drug that is used for CML, to treat CML. It inhibits the Philadelphia chromosome. What happens in Philadelphia chromosome is that there's a chromosomal translocation, so two chromosomes break apart and then they fuse to each other. So that it creates a fusion of two different genes that were on the two different sections of the chromosome, the BCR gene and the ABL gene. When the translocation happens, you get a fusion of those two genes together. This BCR-ABL tyrosine kinase is responsible for part of the phenotype of the tumor. So this particular drug inhibits that tyrosine kinase. It also inhibits kinases that are encoded by two other particular genes. So this drug works in one of three cases. So they have different diagnostic tests. If you test positive for any one of these particular genes in the tumor tissue, you're looking at the KIT gene, PDG, FRB, or the BCR-ABL fusion, then if you have any one of those biomarkers, then this drug is recommended. Without any of those biomarkers, it is not an effective therapy. And the last kind of PD drug that I'm going to talk about is trastuzumab. I may be pronouncing that incorrectly. Basically, it's called Herceptin most of the time. This is the generic term, but most people will refer to it as Herceptin. Herceptin is used to treat breast cancer, but only in cases that are HER2 positive, have HER2 overexpression. HER2 gene has been relabeled as ERBB2. But officially by the Human Genome Nomenclature Committee, but historically it was referred to as HER2. So if you hear either one, they're talking about the same thing. The diagnostic test looks for overexpression of this particular gene. You can detect that one of two ways, by immunohistochemistry, or you can look at a gene amplification assay. So if you can detect the fact that there is HER2 overexpression, then those patients only have been shown to benefit from Herceptin. And so the requirement by the FDA is that you have to use this diagnostic test before you can prescribe that therapy.